think we have some time for some questions. Yes.
First of all, thank you very much. Both times you've come, it's been enlightening, always, stimulating.
Excuse me.
I think they want you to use the microphone, given that others are.
I'm usually so loud that I don't need it. Thank you very much for coming in. It's always stimulating and exciting. The evidence is strong. One of the challenges with the evidence always is what's the opportunity cost for some of these interventions that actually do cost money. So we need to draw the circle larger. Is there any evidence that kind of looks at those trade-offs? My colleagues and I at one point did an informal look at the dollars per quality for public health interventions versus interventions in education, because maybe we should be, if to the extent there is a limited pot, I won't say fixed, but to the extent there's a limited pot, certainly in the short term, should we be shifting some of our resource allocations among these sectors with the intent of improving health?
I think that's a really good question. So let me say two things. I think for many of the interventions, I think I showed the data for the Perry Preschool project, but it exists for multiple other interventions where they've looked at cost-benefit analysis. And if you take a long-term view, not necessarily in a 2-year view, but if you take a long-term view, there is the cost benefit. It is in the financial interest of society to do them. I think that the broader issue you raise is really an important one, and it's one that I don't think we have a clear sense. So we know that all of these social policies affect health, but which ones should we do first? We all think that early childhood is good because if you intervene in early childhood, there are the ripple effects and you have the longer window of time to reap the benefits. But across multiple policy options, I do not think that now we have a good empirical base to know which ones should we begin first, which one should be the foundation, which one should we build on, and how do we roll this out in a way to achieve maximum efficiency and maximum impact. I think that's a research agenda. I do think that, though, that is not a reason to say we just sit back and wait till we get the data and do nothing. But I agree with you that that is, to me, an important issue that we need to look at. Thank you so much. Yes, I think all the way at the back. I think if you can come to the microphone.
Yes, I was just going to say that if to save a little time, if people could line up at the 2 microphones, that would be extremely helpful and facilitate this. David?
Thank you.
Please.
First of all, I'd like to say thank you very much for your presentation. It was very enlightening, very evidence-based. But as I listened, I was excited to sort of hear the context in which you articulated, but at the same time, really frustrated. And the frustration really comes from having to go through so much rigor, individuals such as yourself, to prove what is so obvious to so many people on a day-to-day basis who have to live in these conditions. And it just makes me wonder, being in a country like the United States, we talk about these issues and we know that they're systemic. And part of the work here is really having to convince policymakers of things that they actually know are happening. So I guess my question to you is, in your experience kind of doing this work, I'm sure you share the same frustration, but what has been your sort of, what are some of your wins in talking to elected officials or people who have the sort of authority to help us change trajectory?
And could you say your name, please?
My name is Fred Collier.
A really good question. I think the issue you raise is real. I think you said we know that the issues are systemic. I think the evidence, Stephanie Roberts' work, for example, and the work of others show that most people don't know. Most Americans don't think of the issues as systemic. People who are suffering from the issues are well aware that they are systemic, and others who are involved tend to be aware, but the majority of Americans don't see the issues as systemic. They see the issues very individual, very values-driven, and don't see the issues as systemic. one of the great issues important issues that I've learned about, and I certainly have learned about this with my work with the Robert Wood Johnson Foundation's Commission to Build a Healthy America, where we did preliminary work with the leading policymakers on both sides of the aisle and in the executive branch. And most of them have never done anything on the social determinants of health. And most of them don't naturally think for them, health policy has to do with coverage and those who are more expansive with quality and cultural sensitivity. But so thinking of factors outside the healthcare system is not where our policymakers normally think. So first of all, we have an educational challenge and a communication challenge there. And secondly, I think given the very deep-seated beliefs in our society about individual values and individual action and behavior shaping individual outcomes, although that's not the reality, that is the beliefs of where people are. I think one of our greatest challenges is how do we tell the story of the plight of disadvantaged populations and the challenges of improving America's health overall, because it's not only the gaps in health, but our health overall in ways that resonate with the American public. And in ways that helps them to emotionally connect and identify with the challenges. I think it's something that we can do, which for me means that we need to be doing a lot more work with communications experts and a lot more work with political scientists if we're going to be successful.
Great answer.
Hi, Dr. Williams. I'm Karen Anderson from the Institute of Medicine, and I'd really like to hear your thoughts about why those very simple educational interventions had such a profound impact.
I didn't do, I think to be best would be to have those who have done the work. I haven't done this work. Walton and Cohen from Stanford have done this work. They come out of this group working with Claude Steele on stereotype threat. Their work is very theoretically driven in terms of what they have identified, the underlying drivers. So I think what they would emphasize is that in terms of the values affirmation interventions, that building a sense of self-worth, and a sense of self-adequacy in these students that helps them to believe that they can do it has pervasive effects across their life and across their perceptions of what they are capable of doing and what they can do. So, and the social belonging intervention again is building that sense of normality of initial difficulties and the sense that you can be successful just as everyone else is. But that is my brief discussion. If you read their work, their papers in science, or their larger work, it's really very rich theoretically in terms of what drives them.
Okay, thank you.
Hi, Dr. Williams. Sandy Magin from the Institute for Clinical Systems Improvement. I liked how you said that healthcare acts as a repair shop. Not that I like that it's a repair shop, but nevertheless, that repair shop is consuming a huge amount of our GDP. That could be redirected if there were leadership to so do that. Do you have thoughts about how we engage that huge repair shop and the leadership to help them understand some of these issues and help us in changing?
With persons like David Kinnick in the room, I don't even want to say anything on the topic because I think Dave has really thought a lot about ways in which we pay for performance and do things like that. I do think that it is, I agree with you completely, it is an important problem. I mean, CDC estimates that no year do we spend more than 2 cents or 3 cents of our total healthcare spending is spent on prevention. So we are really largely a curative system and a greater emphasis on prevention. I think there's more recognition of prevention now than there has been historically. The last 10, 15 years, there are more initiatives. The ACA legislation, stimulus spending, did a lot to put prevention on the burner as options and opportunities. So I think we're making progress, but I would say there's a lot more work to be done.
Thank you for your presentation, Dr. Williams. Terry Allen from the Cuyahoga County Board of Health in Greater Cleveland and from the National Association of City and County Health Officials. I'm sitting here thinking about Ohio at the moment, where I live, and the fact that we now are dealing with a challenge in 8 urban areas where the state of Ohio has the largest, we're 50th in the country in the black-white infant mortality gap. And that is a tragedy at many levels. And so thinking about we're at the early stages of a 3-year process, cascading interventions, the order of what occurs or could occur based on the evidence base that you described. Do you have any initial thoughts about getting traction early? There's some of the, certainly the self-affirmation interventions given in one class session. There are some things that you can begin to do to get early wins, and there are a series of economic, perhaps employment opportunities that may be promoted that may have impact. And your sense, just in your mind, of a way to begin to get traction. And we may be calling you in Ohio, certainly, for your insight.
I've been to Ohio a couple times last year,
Okay.
but I think it was in Cincinnati, not in Cleveland. But there's a lot that can be said. But let me give you an example from an unlikely place. I'm not sure if I mentioned it the last time I spoke or not. But the country of Iran has done something that we haven't done in the United States. In Iran, there was an urban-rural infant mortality gap that was twice as high in rural areas than in urban areas. And Iran implemented a primary care system that eliminated that urban-rural infant mortality gap in less than 2 decades. Doesn't exist anymore. And the system existed within every community of 1,000 to 1,500 people. They established a health house. And in this health house, there were 2 providers, a male and a female, high school education, who had worked for a year as an apprentice with a nurse or physician, and with the female doing screening and monitoring of pregnant women, and with the male doing sanitation outreach outside of the health house, and with a referral clinic with 3 or hospital, small hospital, that was their referral source for any problems they identified. And with this program of locally based lay health workers, screening and referral, in less than 2 decades, they eliminated the gap. There is a plan. The Jackson Medical Mall in Jackson, Mississippi, has applied to DHHS for to open 10 centers in the Mississippi Delta, following the Iranian model, using women on welfare as the primary care providers, and doing initial prevention and screening and options in the United States, but explicitly following the Iranian model. So there's a lot that can be done. We also have experimental evidence from studies in Washington, D.C. and so on, that if you do an intervention with pregnant women that addresses not only their healthcare needs, but also addresses issues of depression and access to employment opportunities. The Nurse Family Partnership Program might be another example as well, but I was thinking of other work that has been done in DC. But taking this comprehensive approach can have ripple effects in terms of dramatically improving outcomes, both health and socioeconomic, for the mother, and definitely outcomes for the child. So I think that there are lots of ideas of things that we can do. Think one.
One last question?
Andy Weber with the Maine Health Management Coalition. I can't believe I'm saying that, having just taken the job. Pam, thanks for inviting David back.
Good to see you,
Andy.
Andy.
Thanks for being here. I hope you come back to all of our meetings. I want to tag on to Andrew Ryan's statement that we have tough policy decisions to make in a constrained economic environment. And for me, I think the magic will come to overcome that barrier is if we can show that social policy, while leading to some investment, actually saves dollars somewhere else. And sort of the analogy in healthcare is that there's a lot of energy now around more investments in primary care because it can reduce hospitalization and downstream costs. Can we do that in some of the areas that you brought in, that increasing the minimum wage will save dollars in terms of unemployment benefits and Medicaid and uncompensated care and a host of other economic analyses where we could show, hey, yes, we got up dollars here, but the downstream savings that we're going to get from that. And that could be a way in this political environment to get over the logjam that we have. Anyway, just a thought.
I think that's a really good point. Let me say two things. I don't believe we have paid attention to the economic cost and benefits for all of the things I have talked about. For some of them we have, where we have looked at it, there is the benefit. We also have to realize that the gaps in health are costing us a lot of money, and there's growing evidence along those lines, with an analysis, for example, showing that if we could give all Americans the health of the college educated, the U.S. economy would save $1 trillion a year. And that if we could eliminate the black-white gaps in the racial gap in health, the U.S. economy would save $310 billion a year. So that there's evidence that the status quo is actually costing us. There's evidence that many of the interventions I've talked about literally save us money. But I do think we need a more systematic effort to try to build that case. And there are efforts along the lines in fact, to make that business case for health and improving health. Thank you so much.
Thank you. David, that was absolutely spellbinding. I know, like we have a lot of opportunity to hear presentations and discussions, but I found that particularly compelling, particularly useful as an introduction to this day of discussion that Pamela Russo and her committee have really very expertly put together. So thank you so much, David Williams, for that presentation. And thank you all for those excellent questions in the discussion that